Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our DKA Pediatric Critical Care Fellowship webinar. Today, we have a very special event, and actually, DKA is one of the devastating problems that we face not only in the ICU, but in the ER and in the ward and everywhere. And if not diagnosed precisely early, the patient might have very bad prognosis. The other reason that this webinar is very special to us is we have very nice diversity of contributors, speakers, and moderators. And here is our agenda today. We are going to start with a talk from Dr. Noha Arafa, who is an associate professor of pediatric endocrinology in Cairo University, Egypt. Then we'll have a DKA new therapeutics and update modalities by Professor Michael Aaron from Boston University. And also we are proud to have Dr. Odira Wankor and Dr. Turki Al-Atibi to moderate this session. Just housekeeping stuff here. If you have any inquiries or questions, please feel free to share your question in the QA box. All attendees should receive the certificate of attendance by next week. And if you would like to enable the transcription option to see exactly what we are saying to be transcribed in your screen, go ahead and activate the show caption option in the lower right-hand corner of your screen. Again, all of these educational activities, events, has no value except we try to apply this knowledge into our clinical practice, try to improve our standard of care, to improve our patient outcome. And the great aim of education is not the knowledge itself, but the action. With that, we are going to start with our first speaker today, Dr. Noha Arafa.
Good evening, dear colleagues. It's my great honor today to share in this webinar about the updates and guidelines of management of children with diabetic ketoacidosis. In the next 20 minutes, we will highlight the hidden pitfalls in pediatric DKA to mind the gap. The global burden of diabetic ketoacidosis in children with new onset type 1 diabetes from different reports from Europe and North America, ranging from 15 to 70% of patients at the onset of the disease, and still the DKA causes mortality. In developed countries, the death rate is ranging less than 1% in patients with diabetic ketoacidosis. However, in developing countries, the rates are much higher, reaching 3% to 13%. And as you see here, we have different guidelines for the management of DKA in children, the ISPAD guidelines and the ADA and other different societies. And although we have these guidelines, there is disparities between the guidelines and the practice, and still we have error happens during the management despite the different protocols. So to mind the gaps, we will go to the DKA basics, and usually what we assume everyone knows often don't. We will divide the stages of the pitfalls into different stages, and we will start with the pre-hospital and the emergency room pitfalls, and we will start with the point of the misdiagnosis. Usually we teach our junior residents that every child have rapid breathing, or the child if presented with vomiting and abdominal pain without diarrhea, checking the finger stick blood glucose is a must to not to miss the early presentation of diabetic ketoacidosis. And we have different atypical presentation, especially in patients that very young, less than 5 years, and if the child have preceding infection that masking the initial symptoms for diabetic ketoacidosis, and if we have euglycemic ketoacidosis. Also, the delayed starting of insulin, although the diagnosis of type 1 diabetes is established, is a common pitfalls that lead to the presentation with a DKA. This published data from our center, we were focusing on the clinical characteristic and precipitating factors associated with diabetic ketoacidosis in children at the new onset of diabetes, and we found out the most important predicting factor for developing of DKA at the diagnosis was the time lapse between the diagnosis of diabetes and starting insulin treatment. I think we are all dealing with type 1 diabetes and DKA, know very well the famous ISPAD guidelines, and we are adapted to management of DKA that's divided into the fluid management and the insulin management. And actually the fluid management part of DKA, it is the most important and dangerous part, controlling the outcome of patients with DKA. And this figure or algorithm for introduction of fluid management in patients with diabetic ketoacidosis have different pitfalls. If we over-resuscitated with fluids before the diagnosis, and another pitfall if we choose the wrong fluids, usually the debate between normal saline and hypotonic fluids, and if we correctly calculated the deficit and also the failure to adjust the fluid based on the sodium trends, and when and how to add the dextrose during the fluid management. And I think that different guidelines trying to focus on the details of the fluid management in patients with DKA. We have also another pitfalls about the insulin therapy, and we have different reported pitfalls like the giving insulin bolus or starting insulin too early or too late, and the wrong dose of insulin infusion, and also the insulin therapy during the hypokalemia, and finally the transition error from the IV to subcutaneous insulin. And we have general rules for insulin therapy that we start insulin therapy within 1 to 2 hours after initiation of the IV fluids, and the dose of insulin infusion ranging from 0.05 to 1 unit per kg per hour, and we dilute 50 units from regular insulin into 50 ml of normal saline by IV infusion. And we have to flush the insulin infusion tubing before the administration. And coming the most important trap, the electrolyte and the metabolic trap during DKA management. And we have different traps like the renal function test, the bicarb, sodium, potassium, phosphorus. And we will start with the silent killer, the potassium. Usually, underestimating the total body potassium deficit is happening, and the ESPAD teaching us that the serum potassium may be falsely normal, and the total body potassium is always depleted in DKA patient, and the insulin and the rehydration will rapidly drop the potassium, so we must replace the potassium deficit preemptively and monitor it closely. Replace the potassium in all DKA patients, regardless of the serum potassium, unless we have renal failure or we didn't detect any urine output. And if we have a patient with hypokalemia at the start of the introduction of insulin therapy or at the initiation of DKA management, so we have to start with the potassium during initial volume expansion and before insulin therapy. And if we have a hyperkalemic patient, please defer the potassium replacement therapy until the urine output is documented, and usually ensure the urine output before routine potassium replacement. And if we are in a limited resource setting and we don't have immediate serum potassium measurement available, we can check the ECG. It can determine if the child have changes suggestive of a hypo or hyperkalemia. Then coming to phosphorus levels, and the most common question, should we replace or not for hypophosphatemia? Actually, hypophosphatemia during the treatment of DKA happening in about 50 to 60% of children due to losses of phosphorus in urine due to the osmotic diuresis and the dilution by the fluid and the introduction of intravenous insulin exaggerate the problem of hypophosphatemia. And the ESPAD teaching us that replacement of phosphorus in severe cases with low phosphorus level less than 1 milligram per deciliter, or if the patient have clinical signs suggestive of hypophosphatemia like muscle weakness, respiratory compromise, or hemolysis, or sometimes cardiac dysfunction. Then the acidosis. I think that we all know that the fluid and the insulin replacement therapy usually reverse the cycle of metabolic acidosis, and the treatment of hypovolemia usually improve the tissue perfusion and renal function, increasing the excretion of organic acid. But when we can use the bicarb therapy during management of DKA. The routine use of bicarb therapy may cause paradoxical CNS acidosis, and rapid correction of acidosis with bicarb causes hypoglycemia. So it's not routinely introduced during the management of DKA. We give the bicarb therapy in certain situations like life-threatening hyperkalemia and unusual severe acidosis less than a pH 6.9 with compromised cardiac contractility. Don't give the bicarb therapy except after senior endocrinologist consultation. And then coming the acute kidney injury. The acute kidney injury is actually with variable degree of the acute kidney injury. It's a variable finding during DKA management. This the frequency of its occurrence ranging from 43% to 64% of children with DKA, and it's actually more common in children with more severe acidosis and those who are more volume depleted. And the extent and the stages of acute kidney injury is divided into different stages, stage 1 and 2 and 3, and it's defined according to the baseline creatinine and the times of its increase during the management of DKA, and usually the restoration of the fluids and correction of electrolytes and the glycemic balance restore normal kidney function. So usually during DKA management, we have to monitor the kidney function every 2 to 4 hours to detect any abnormalities in the kidney function. And coming the most terrifying complication that we all the endocrinologists managing patients with DKA are terrifying from the occurrence of cerebral injury. What about the incidence of the cerebral injury? The occurrence of mental status abnormalities with variable degrees, it actually occurs in children with DKA with a frequency ranging from 4% to 15%. However, the incidence of clinically overt DKA-related cerebral injury is a minimal percentage with 0.5 to 0.9%. But if the cerebral injury occurs, actually the mortality rate is high, about 21 to 24% of patients with clinically overt cerebral injury. Then what are the risk factors of cerebral injury? Actually, the risk factors there are factors related to the patient and some other factors related to the biochemical risk factors. Regarding the factors related to the patient, the younger children, the new onset of diabetes, and the longer duration of symptoms before the diagnosis are risk factors for the cerebral injury. However, the biochemical risk factors like the greater hypocapnia at the presentation, increased the serum urea nitrogen, more severe acidosis at the presentation, and the use of bicarb treatment for correction of acidosis are risk factors for development of cerebral injury. And regarding the diagnosis of cerebral injury, the timing when to suspect the occurrence of cerebral injury, usually within the first 12 hours after starting treatment, but can occur at the time of the presentation, and rarely it can occur late during 24 to 48 hours after starting treatment. And the diagnostic criteria for cerebral injury, we have diagnostic criterion and major criteria and minor. If we have one diagnostic criteria, it's sufficient for the diagnosis of cerebral injury. And if we have two major criteria or one major and two minor criteria, it's sufficient to diagnose that this patient having cerebral injury. So what about the diagnostic criteria that we have? We have a list of diagnostic criteria. If we have one criteria, so our patient having a cerebral injury. This diagnostic criteria like abnormal motor or verbal response to pain, decorticate or decerebral posture, cranial nerve pulses, especially nerves 3, 4, or 6, and abnormal pattern of a respiratory pattern like the grunting, tachypnea, and kind-stroke respiration. And regarding the major criteria, the alteration in the mental status and sustained heart rate deceleration or age inappropriate incontinence. If we have one major, two major criteria, so it's satisfactory to diagnose the cerebral injury. And regarding the minor criteria like the vomiting, headache, lethargy, diastolic blood pressure more than 90%, or the age less than 5 years, it's the minor criteria for diagnosis of cerebral injury. What about the treatment of cerebral injury? Should we wait for the neuroimaging? Actually, no. We have to initiate the treatment as soon as the condition is suspected, and the neuroimaging is not required for the diagnosis of cerebral injury, but sometimes when the imaging is warranted. Actually, the patient who have a focal neurological deficit that may require the emergency neurosurgery like the intracranial hemorrhage and the lesion that may necessitate the anticoagulation like the suspicion of occurrence of cerebral vascular thrombosis. Those are the conditions that warrant the neuroimaging before the institution of the treatment of cerebral injury. And regarding the treatment of cerebral injury, the brain dehydrating measures in the form of mannitol of hypertonic saline. Regarding the mannitol, the dose is 0.5 to 1 gram per kg IV infusion over 10 to 15 minutes, and we expect the effect of mannitol after 15 minutes, and the duration of its action about 120 minutes, and we can repeat the dose if we didn't have a satisfactory improvement after 30 minutes. Regarding the hypertonic 3% saline, the dose is ranging from 2.5 to 5 ml per kg over 10 to 15 minutes, and it can be used as alternative to mannitol or addition to mannitol if we had no response to mannitol within the 15 to 30 minutes. Regarding the fluids, adjust the fluid rate to maintain a normal blood pressure, and we have to avoid the excessive fluid and the hypotension. We have to avoid the excessive fluid intake as it exaggerates the cerebral edema, and we have to avoid the hypovolemia and the hypotension, hypoperfusion to avoid the cerebral perfusion, as it compromises the cerebral perfusion pressure. And what about the intubation? Some patients with impending respiratory failure may need intubation, and we have to keep the PCO2 level approximate for the predicted level of metabolic acidosis. And usually during the intubation and ventilation of patients with cerebral injury, avoid hypocapnia, except if it's indicated if we have clinically overt elevated intracranial pressure. And I think that we all know the famous Picard study published 2018, and the target from this trial was investigated the type and the fluid infusion rate during the management of patients with DKA regarding the neurological outcome. And the conclusion was that neither the rate of administration nor the sodium chloride content of intravenous fluid significantly influenced the neurological outcome in children with diabetic ketoacidosis. And we have actually other cerebral central nervous system complication in the form of cerebral venous thrombosis and basilar artery thrombosis, intracranial hemorrhage, and cerebral infarction, but it's less common than the brain edema. And this is the famous ISPAD clinical practice consensus guidelines, which is very illustrative for management of patients with diabetic ketoacidosis. And finally, the learning points that the DKA management is dynamic, not algorithmic, and the protocol don't replace clinical judgment, but judgment needs humility. And thank you so much.
Thank you so much, Professor Noha, for this very nice, quick, and updated information just in 20 minutes. It's very hard task to collect all of this information in this very nice, concise presentation. Thank you so much. And our next speaker would be Dr. Michael Aaron, who spent most of his career in Boston University, and now he's in San Joe University Hospital. He is a pediatric critical care physician with a special interest in pediatric endocrinology, and is going to give us the up-to-date information on DKA diagnosis and management.
Yeah.
Why does one get hyperglycemic in DKA? Why does the blood sugar go up at all? Well, it's really the same reason you get hyper-anything-emic in any clinical situation. It's some mismatch of increased ins and decreased outs. So what are the increased ins of glucose into the bloodstream? Well, one major one is the one that patients are doing at home. What are they drinking at home? In general, they're drinking Pedialyte or juice or some dextrose-containing fluid. And they don't realize that they're driving their blood sugar higher and higher. The other actor that's adding glucose to the bloodstream is the liver. The liver believes the blood sugar is extremely low because it can't get any glucose intracellularly because of the insulin deficiency. And so it turns on gluconeogenesis at full throttle. And of course, that's also what produces the ketoacidosis, the lipolysis, freeing up those circulating ketones, free fatty acids as well. Now, where should the glucose be going? Well, if insulin were present, there'd be normal cellular uptake. But with decreased insulin production, increased insulin resistance, there is a functional severe insulin deficiency, and so there's dramatically decreased cellular uptake. Now, these three factors will give you blood sugars in the mid to high 100s. What really pushes you over the edge is when you begin to decrease perfusion to the kidneys. We know that the renal threshold is about 180, and if your blood sugar is anything over 180 and you're adequately hydrated, eventually the kidney will dump all that glucose. It may get dehydrated in the process, and you'll need to replete those fluids. But the glucose should come down. In the setting where you begin to hypoperfuse the kidneys, that's when the glucose really shoots up. And that's when the glucose will hit the 800, 1,000, 1,200 milligram per deciliter range. One important caveat to the construct I've mentioned here is the middle-aged or adolescent patient who happens to be at home rehydrating with water. That's the one patient where the glucose may not be as elevated. The glucose may be only in the 400 range, 500. They may have quite significant diabetic ketoacidosis. However, they are not as dehydrated as the usual patient with DKA. This is a rare patient, but it's a patient where you really want to think twice when the blood sugar is not that high, to ask yourself the question, maybe the kidneys are a little bit better perfused than I'm used to, and maybe they don't need the amount of fluid that I'm about to give. But for most patients, they come to the emergency department, they have a blood sugar in, say, the 1,000 range, and they will get their normal saline bolus, usually 10 milliliters per kilogram over the first hour, and that will almost invariably significantly drop their blood sugar because we saw in the prior slide, we're now reperfusing the kidneys. The kidneys are now able to dump glucose and as such, the glucose will begin to plummet. After a few hours, the trajectory of that glucose concentration will change. And now you're looking at the effect of insulin. Insulin will significantly decrease the glucose concentration, but it won't do so at the rate that reperfusion will. We know that if we don't do something about the glucose decrease as insulin infuses, is it will go all the way down to 0. But we maintain a target range of about 150 to 250, and in many hands the appropriate range is really 200 to 300 milligrams per deciliter. And we achieve that range by adding in dextrose to our IV fluids. Now, one has to understand that the range here is chosen really to make sure that glucose doesn't go severely low. A patient is in much better shape if they spend the whole night at 250 than if they spend the whole night at 120. If they spend the night at 120, they're at risk for dropping low at any moment. And if not adequately monitored, they can be at significant risk for hypoglycemic seizures. As I mentioned at the beginning, DKA is a problem of insulin deficiency. The cure for DKA is insulin therapy. Glucose is really an innocent bystander. It's affected by insulin therapy, but it's not part of the problem. The problem is insulin deficiency, and we need to correct that problem.
Management.
The normal saline bolus. In the emergency department, we will generally give 10 milliliters per kilo, and that's been a component of most treatment algorithms throughout most of the literature. The real question is, do you give that second or third or fourth bolus? And it is extremely uncommon to need much volume beyond 10 per kilo, and beyond 20 per kilo is extremely rare. Now, one has to resolve and kind of internally understand that unlike almost every other volume bolus we give in pediatrics, the idea of the volume bolus in DKA is not to restore euvolemia. It is to restore end organ perfusion such that those end organs don't suffer significant injury. The amount needed to restore end organ perfusion is very small. The amount needed to restore euvolemia is quite significant, but if you restored euvolemia in every patient with DKA, you would be doing a lot of harm. That's why we restrict fluids to 10 per kilo in general, 20 per kilo rarely. But I will say that in the extremely unlikely situation that someone comes in with DKA and shock, they may need 80 per kilo. So there is no correct amount of fluid to give a patient with DKA. You give the patient what they need. But again, it's not what they need to get to be euvolemic, it's what they need to avoid end organ dysfunction due to ischemia. In terms of insulin therapy, it's really amazing to remember that the serum half-life of IV insulin is between 3 and 5 minutes. Insulin is very quickly utilized or broken down in the serum. And so one achieves steady state with a continuous insulin infusion, at least a steady state concentration within 3 to 4 half-lives or 15-20 minutes. So the utility of an insulin bolus was always a little bit in question. Recently, however, though, there was an interesting cohort study in the United Kingdom which demonstrated that any insulin given in the first hour increases the risk of significant cerebral edema quite markedly. And so we've now shifted away from giving any insulin in the first hour, and we certainly don't give any boluses at this point. So based on all this data, we proceed by giving our normal saline bolus, as I mentioned, usually 10 mLs per kilo over the first hour. And at the end of that first hour, we start the insulin infusion without a bolus, without a loading dose. We give it at 0.1 units per kilogram per hour as a continuous infusion.
Fluid and electrolyte therapy.
Fluid and electrolyte therapy. In terms of choosing what rate of fluid to infuse, it was years ago that we were encouraged to look at a patient and decide what percent dehydration that particular patient had. This one looks 2.7% dehydrated, this one looked 3.4% dehydrated. We began to realize based on some nice data, that a handful of expert clinicians would all choose a slightly different percentage when they look at the same patient. And so we really don't have a very good ability to assess total fluid deficit just by looking at a patient, even when we have access to patient prior weights. There's certainly dehydration that takes place over a period of weeks, but there's also muscle loss, there's lipolysis going on, and some of the weight loss may not be attributable to fluid loss, and may not be appropriate to adjust your fluids based on that. And so there's now an international consensus statement that guides the therapy that I'll be telling you about, and specifically refers to the rate of fluid administration and choosing a rate between 1.5 and twice maintenance. In general, after getting the appropriate bolus, I would start with 1.5 times maintenance. From a dextrose point of view, we start with no dextrose in the infusate, assuming that the patient is hyperglycemic. If it's the rare patient I mentioned where blood sugar is 300 to 400, I would put in 5% dextrose into the solution. But in general, we start with none, and we ratchet up from 5 to 10 to 12.5%, being the highest concentration I would infuse peripherally. Remember that going up on the dextrose should be considered a ratchet. Once you go up, there's no real reason to go back down. As I mentioned, blood sugars 300-400s are okay in DKA therapy. Sure, the 150 to 250 is the ideal range, but it's just not worth the expense, the hassle, the risk for errors by changing the fluids more than they absolutely need to be changed. And so from a dextrose point of view, again, I'd march up from 0 to D5 to D10 to D12.5 every time a blood sugar approaches 200 milligrams per deciliter. From a sodium point of view, I've mentioned to you that there are no data to suggest that sodium administration makes a difference in the risk of significant cerebral edema. Despite this, there are some anecdotal data which have, I think, guided our practice, and the international consensus statement now states that for the first 4 hours, we ought to have a sodium concentration in the infusate of 154 millimoles per liter. That, of course, is normal saline. And we all agree that for the first 4 hours, we're going to stick with normal saline. At that point, however, I recommend dropping to half normal saline. If we use normal saline the entire course of therapy, every patient can end up hyperchloremic with a non-GAP acidosis. Now, a non-GAP metabolic acidosis is not a dangerous acidosis, but it doesn't feel quite so good. And so those patients may be slower to convert to sub-Q insulin. They may not be in a mood to get all their diabetes education, and they may end up with a longer length of stay because of the hyperchloremia they've had in their initial therapy. So I try to reduce from normal saline to half normal at that 4 hour mark. If the serum sodium is particularly low or particularly high, those are situations where I might continue the normal saline for a little bit longer than just the first 4 hour mark. Now, from a potassium point of view, we'll talk about insulin effects on potassium in a second, but it is clear that patients in DKA are total body potassium depleted. And so we think of the baseline potassium concentration in infusate for diabetic ketoacidosis to be about 40 milliequivalents per liter. The range of acceptable peripheral concentrations is between 20 and 80. When you get up to 80 milliequivalents per liter, you may be in a very high range, and we'd only do that if the serum potassium is really in the low 2 range and just not responding to the concentrations we're using. When one is following potassium, one can always look at an electrocardiogram to look for the presence of U waves. But in general, hypokalemia, although we certainly try aggressively to avoid it, is not a lethal complication in DKA, and one shouldn't overreact by giving potassium infusions. Rather, put it in the IV fluid, and the patient will eventually equilibrate over time. In our institution, we use acetate and phosphate to replace some of the chloride, to avoid giving as much chloride as we might otherwise give. So instead of giving potassium chloride in the infusate, we give a combination of potassium acetate and potassium phosphate. Now, potassium acetate can be given in significant concentrations. Potassium phosphate, one has to be a little bit concerned about the relative concentration of phosphate and calcium. Phosphate and calcium are acutely co-regulated, and if one infuses a lot of phosphate, the calcium will plummet, and you can develop hypocalcemic tetany as a complication of giving too much phosphate. And so we limit the phosphate in the infusate depending on size. From a calcium and magnesium point of view, we don't tend to need to replete those at all.
Metabolic effects of insulin.
Now let's review the main effects of insulin. We know that insulin pushes intracellularly glucose. That's its main function. It also has a similar effect on potassium. We also know that the patients present total body potassium depleted due to the acidosis. In the setting of acidosis, cells will try to help to reduce the proton concentration, and that's basically what acidosis is, right? Increased proton concentration. The cells will try to help by sucking in a few protons and exchanging them electroneutrally with intracellular potassium. As a result, the extracellular potassium will begin to rise, and when the patient is home and the patient is still well perfused, or the kidneys are still well perfused, the kidneys will dump that potassium. So by the time the patient comes into the emergency department, they have been dumping potassium all day long and are total body potassium extremely depleted. Now, a similar situation happens with phosphate. Phosphate can be very low in starving or malnourished people. Some believe, have learned about the refeeding syndrome, meaning the risk of refeeding and developing catastrophic hypophosphatemia from anorectic populations. The truth is, it was first described, unfortunately, in the Holocaust when Allied soldiers freed concentration camps. And when they saw these poor, emaciated, tortured prisoners, they said, you guys haven't eaten in such a long time, here, have a little bit of a candy bar. And the prisoners would eat a little bit of candy bar, and many of them would have a cardiac arrest on the spot and die. Now, why did that happen? It happens because insulin is phosphorylated at the receptor, and so insulin uses up a significant amount of free phosphate. If your free phosphate concentration is extremely low, and you give what amounts to as an insulin bolus, meaning it's insulin infusion at a significantly high dose, which is what we do, you can quickly use up phosphate stores if the circulating phosphate levels are extremely low, and all of a sudden you have no phosphate to make ATP from. In that situation, you will have instant death of high metabolic tissues like the heart, and that will lead obviously to whole organism death. It's easy to avoid hypophosphatemia, or at least critical hypophosphatemia, by maintaining an infusion of phosphate, as I mentioned, in the form of potassium phosphate, somewhere between 15 and 20 milliequivalents per liter if one is infusing the total fluids at between 1.5 and twice maintenance. That really is an adequate phosphate delivery in order to avoid critical hypophosphatemia. It's not going to get your patient's phosphate up to a normal of 4, but it will keep it in the 0.8 to 1.2 range, or potentially above that. And that will keep it high enough so that one won't develop the potentially lethal complications of critical hypophosphatemia.
Monitoring the patient.
Now, while one is treating a patient with DKA, one has to follow frequent lab values. We recommend following a blood glucose value hourly. That can be a finger stick during the time periods that you're not drawing an actual blood sample for electrolytes. Every 2 hourly, we look at electrolytes, meaning a Chem 10, and by that we mean sodium, potassium, chloride, total CO2 or bicarbonate concentration, BUN, creatinine, glucose, calcium, phosphate, and magnesium. we usually draw this from a second IV. And so we will have an infusing IV with insulin, and we will have a second IV where we infuse the IV fluids, and we will withdraw from that when appropriate in order to measure glucose concentration and the electrolytes. If one is drawing from the line where dextrose was infusing, one has to be very careful to have an adequate waste, at least a full ml of blood, in order to not contaminate the measurement with a dextrose infusate. Another way to measure electrolytes is with a venous blood gas. It's important to remember that although these are valid values, they are not directly comparable to serum electrolytes. Whole blood values can be a few percentage points off from serum values. We also occasionally will measure some form of continuous CO2 monitoring, either end-tidal CO2 or transcutaneous CO2, in order to confirm that the patient's PCO2 concentration is rising normally. It will often start in the very low teen range, even as low as PCO2 of 10 millimeters of mercury. But it should rise towards the normal concentration of 40 as the therapy is delivered. If that rise begins to be flattened or goes in the opposite direction, then something is wrong. Usually there's a problem with the insulin delivery system that needs to be relooked at, or occasionally the insulin concentration was not mixed properly in the pharmacy. We conduct a Glasgow coma score every 2 hours in order to help bedside clinicians identify a change in mental status that might require further evaluation and consideration for therapy.
Titration of fluid therapy.
Now, there's two approaches to adjusting fluids in diabetic ketoacidosis. The one that we use in our institution involves having a pre-made set of fluids that we keep in the unit where we predominantly care for diabetic ketoacidosis. There are 4 concentrations of fluid. They're all normal saline, but they have no dextrose, D5, D10, and D12.5, along with a mixture of 25 milliequivalents per liter of potassium acetate and 15 per liter of potassium phosphate. By having these 4 fluids pre-made and near the patient, as the blood sugar goes down and the provider wants to increase the dextrose delivery, they can order that fluid, and that fluid can be hung by the bedside nurse within minutes. And using this approach has nearly eradicated the incidence of hypoglycemia during insulin infusion, because this means that the provider will not write the order and leave the unit. The nurse then ends up waiting up to an hour until the pharmacy can make that fluid and increase the dextrose concentration to the patient. In the meantime, the patient's glucose has been falling steadily. And so we've been able to really eradicate hypoglycemia with this method. The other approach that many hospitals use is a titration method, where they have a high concentration dextrose fluid in one bag and no dextrose in the other bag, and they change the concentration of dextrose by varying the relative infusion rates. This makes a lot of sense to me. Personally, I have not seen it in action, and worry about the training required for bedside nursing and how the orders would need to match in our current situation of computerized order entry. In addition to ordering the pre-made fluid, we also ask the resident or the provider to order the fluid that they really want if it's different than the stored fluid. Maybe they really want D5, for example, with 12 of K-phos and 19 of K-acetate. That's fine. But in the meantime, they'll get the pre-made D5, and then 45 minutes, an hour later, they'll get the fluid that they really wanted from pharmacy. Now, what do we do to maintain euglycemia? I mentioned earlier that we increase the dextrose in steps, and I consider it a ratchet. So we go up, we don't go back down. There's just no reason to go back down. We start with no dextrose, go to D5, D10, D12 and a half. Once we hit D12 and a half, then, and the blood sugar is still in the mid to low 100 range, as in less than 150, then we need to go up on the rate of IV fluid. And so we would go up from 1.5 to twice maintenance. Now, virtually all patients, the great majority of patients, will finish their course of therapy on D12 and a half at twice maintenance. If you're on D12 and a half, if your patient is on D12 and a half at twice maintenance, and the blood sugar is still going down to the low 100s, then and only then you may need to think about reducing the insulin infusion rate. Personally, I don't advocate decreasing the insulin infusion rate in almost any circumstance, because I think that it can introduce error into the system. And if a nurse or a provider that's relatively inexperienced believes that insulin is one of those things they can titrate along with the dextrose and the fluid rate and all the electrolytes, then the patient may end up not getting the adequate dose of insulin they need. Now, what is the adequate dose? I've told you that I recommend 0.1 unit per kilo per hour. Is that definitive? Is that what's required? No, it's not. In fact, there have been some data to suggest that a lower dose may be adequate in many, many patients. But I can tell you that 0.1 unit per kilo per hour is adequate in all patients. And we've never had a case, despite having seen hundreds and hundreds of patients with DKA, where that dose was inadequate. And so I fall back on using an adequate dose for everybody and supporting it with dextrose and with the appropriate IV fluid rate in order to maintain euglycemia and resolve the diabetic ketoacidosis. 0.1 units per kilo per hour is a massive dose. It's 2.4 units per kilo per day. The usual diabetic will be on, once they finish their honeymoon period and they've settled into their diabetes, they'll be on about 1 unit per kilo per day. So this is 2.5 times the usual maximum dose for a patient with diabetes. But the idea is when they come in, they have a lot of insulin resistance. And as that insulin resistance goes away, the insulin effect goes up and up, even though the dose is the same. And that's why we need to increase the dextrose supply. We need to increase the fluid supply as the patient moves along.
That's a very nice presentation. I will let Dr. Idira and Dr. Turki Al-Atibi to moderate the session, and I think we have tons of questions. I'm very sure we are not going to answer all of this, but good luck, Dr. Idira and Dr. Turki.
Yeah, I once again welcome all of you to the webinar. These DKA
Dr. Idira, unmute yourself.
Yeah, can you guys hear me? I muted myself. Can you hear me?
Yes, yes, yes.
Excellent. Now, I was just saying that the DKA webinar is just phenomenal. I think Dr. Doha did a great job in discussing the ISPAD guideline. And from the number of questions we have here, I think this tells us that it generated a lot of interest. I don't know that we'll have so much time. I'm just going to go through a few of the questions, and I will start with the first one. This first question will go to you, Dr. Noha. It says, thank you for the beautiful presentation so far. Please elaborate on the euglycemic DKA.
Yes, hello everyone. The euglycemic ketoacidosis, we will start with the definition of ketoacidosis, like what elaborated here in the session. The pH is, according to the latest ISPAD guidelines, the pH is less than 7.3 and the bicarb is less than 18. And the euglycemia, it means that the ketoacidosis is fulfilled with normal blood glucose. And usually this situation occurs in patients using oral hypoglycemic drugs combined with the insulin therapy. And we sometimes see these patients in the already diagnosed patient with type 1 diabetes already on insulin therapy during the 6-day mismanagement, not the adequate management. And sometimes we see these patients on insulin pump therapy when the pump therapy is disconnected. And this is the meaning of euglycemic ketoacidosis.
Very
Do you
good.
see it
Thank
also
you so
with
much.
SGLT2 inhibitors, or you don't use it?
Yeah. Actually, we usually don't use it in patients with type 1 diabetes.
And thank you so much. I think the two other conditions where you could also get this, some pregnant women also might come in with euglycemic DKA. And
yes, actually, I'm dealing with children.
I know, but you can get some pregnant teenagers.
Yeah.
And and those who have actually starved, who haven't eaten in a long time before they're presented with DKA could also come with this. I think what is really important is that at the start of your rehydration, because the glucose level is almost normal, like 200 to 250,
yes,
you have to start them with dextrose fluid at that point. Very, very important that we do that. I'm going to go with the second question, and I'll let Dr. Turkey take the next two questions.
Yeah, okay, thank you, Dr. There's a question about, you mentioned the type of the fluid. They are asking, can we use ringerl lactate as one of the choice?
Yes, actually, all the guidelines till the ISPAD guidelines was the recommendation regarding using the normal saline for the resuscitation therapy. But actually, there are a lot of recent trials for comparing the normal saline versus the ringer lactate, and actually the results are promising regarding using the ringer lactate. The previous fear was regarding the accumulation of lactic acids in using this type of the fluid, but the results was promising regarding the arms of ringer lactate using, as its balanced solution and concentration of chloride is less than using the normal saline. So these patients are less liable to develop the hyperchloremic metabolic acidosis. I think this guidelines and the recommendation regarding the type of the fluids will soon change according to these results.
Okay, very good.
Dr. Turkey, also, I think if the patient is shocked, and if we give a lot of fluid for resuscitation, the LR might be a good option, because too much normal saline would induce hyperchloremic metabolic acidosis. That's also injurious to the renal tubules and causes vasoconstriction to the afferent arteriole, so might increase the AKI incidence. But again, here we are, because also this was very nicely illustrated by Mike, that we don't give a lot of fluids, 10 cc, per kilogram, maximum 20, as long as the patient is not shocked. And our target here is not to treat dehydration. Our target is to perfuse the organs.
Very good. I'm going to go with the next question. And I think this question, maybe Dr. Khalid could take this one, if you don't mind. It asks when to think of cerebral injury in the context of DKA, clinical versus imaging, the treatment monitor versus rehydration. I don't know if you understand the question.
Unmute yourself, please, Dr. Khalid.
Yeah, can you hear me now?
Yeah.
Yeah, okay. Regarding cerebral injury, when we go back to ISPAD guidelines, which we are depending regarding pediatric and adolescent diabetes, cerebral injury regarding diagnosis depends on clinical criteria. We have major and minor criteria, and there is no evidence that we should depend on imaging. For this, not to be late for diagnosis of cerebral injury or cerebral edema, to wait for CT brain or any brain imaging. For this, we should start management immediately when we have clinical criteria suggesting cerebral edema, like mild head elevation in third degree, good ventilation, and also we may be in need, as you mentioned, to go aggressively with mannitol. And also, if we started to manage with mannitol, we can get a chance to give another shots if we don't have clinical response within 10 to 15 minutes. Sometimes many junior doctors, they wait for clinical response for 1 or 2 hours, and this is too late. According to SBAT guidelines, we can start management with mannitol or hypertonic saline, and if there is no response clinically within 10 to 15 minutes, we can go again and give again shots with mannitol. And regarding the question, we are depending on clinical criteria more than confirming the diagnosis on imaging.
Very good. The only thing I'm going to add is between mannitol and 3%. If you have mannitol at your institution, please go ahead and give it.
Yeah.
But if you have both mannitol and 3%, it will be better if you start with 3%. The reason that I said this is that mannitol is an osmotic diuretic. That if you have a DKA kid that is already markedly dehydrated and you give mannitol, that may worsen the situation. And mannitol also increases the osmolar gap sometimes. That if you have an increase in osmolar gap, you might also risk some sort of acute kidney injury. I said this to say that you have to have 3%. If you don't have, please go again and give your mannitol 0.5 to 1 grams per kg and run it over 15 to 20 minutes. If you have 3%, you can do 3%. We usually do 2.5 to 5 cc's per kg, and you can always repeat that. Dr. Taki, I'm going to let you take the next question.
Doctora, for Dr. Noha, you present about one of the association or complication DKA, the hypophosphatemia. So there is a question here: what could be done for maintaining serum phosphate level in the setting where no phosphate infusion? Is there any way in the protocol and the guideline about adding phosphate infusion?
The first point that during the management of DKA, we are expecting that the hypophosphatemia will occur. And the guidelines are talking about the using of phosphate in different preparation of the potassium phosphate instead of using the potassium chloride. Actually, in our center and in Egypt, we don't have the potassium phosphate to use it in exchange of the potassium chloride. So I think in the limited resource setting, in a shortage of this preparation, the only solution that we have to monitor the phosphorus during the management of DKA, and once the hypophosphatemia occurs, we have to treat it. But if we have this preparation, okay, we will use it from the start.
Very good. I'm going to ask this question. I hope we'll still have time, but I think it's a very important question. Dr. Khalid, if you don't mind to take this one.
Yeah.
He says, thank you. And how do you see and your recommendation of insulin therapy in low, I will imagine it's low limited settings, area where there is no infusion pump? I guess this question is, how do you deliver insulin in a low resource environment without an IV pump?
Yeah, recent recommendations of SBAD didn't recommend something like this, because when we have insulin shots, that means we may lower the glucose more rapid or faster than the rate of IV fluids, and this will not be equal all through the time. For this, no clear recommendations, even in low setting area, regarding insulin boluses against insulin infusion?
This is a
I
little
think
bit,
it will be so risky.
yeah, it's a bit confusing to me, but I think it's something that we really need to look into, because I know that most of the hospitals in low-resource setting do not have IV pumps. I was just wondering if there's a way to calculate.
Can I
Yeah.
share
Yes,
a
please
point?
go ahead.
I think
Yeah.
if we don't have the insulin infusion pump, I think there is another sets that we can use to deliver the infusion, like the solo set. We can calculate the doses using other sets. And in the era of the COVID, I think it was a real challenge for all the doctors and the pediatrician to treat those patients along the way and away from the hospital. And as Khaled said, regarding the shots of subcutaneous insulin, it was recommended in patients with mild DKA. But the severe DKA, delivery of subcutaneous insulin infusion, I think it's the mandatory point. But for the mild DKA, we can give the rehydration and give these shots every 2 hours for the correction, with higher doses of correction doses, and using the long-acting insulin like the usual daily dose. But in severe DKA, it's not applicable to use other methods except the infusion with different infusion sets. Thank you.
Thank you so much, Dr. Noha and Dr. Khalid. Dr. Ahmed, how much time do we have? There are so many questions here. Should we continue?
Yeah, 5 minutes should be fine.
Okay, good. Good. There's another question here. Dr. Noha, if you don't mind to take this. It says, is hemoglobin A1C important in pediatrics or to pediatrics with suspected type 1 diabetes mellitus?
Actually, the diagnosis of type 1 diabetes is very clear in all the guidelines, in the ADA guidelines and the ISPAD guidelines. And it's stated that if we have a patient with typical symptoms in the form of polyuria, polydipsia, and the loss of weight with random blood sugar more than 200 milligram per deciliter, it's satisfactory to diagnose type 1 diabetes without waiting for any further sophisticated investigations. But if we screen for the diabetes, we have to confirm in asymptomatic patient for the diagnosis, as it's catastrophic event for the family and for the lifelong management plan for this patient. In asymptomatic patient, we have to confirm the diagnosis with either of one of the tools of investigation, either to have the fasting plasma glucose more than or equal to 126, or the 2-hour postprandial more than 200, or the glycated hemoglobin more or equal to 6.5. And if we have any problem regarding the hemoglobinopathies, which is common in our African countries, it will mask the diagnosis. So it's not the mandatory, but it's part of the diagnostic criteria. But don't wait for it if you have a symptomatic child.
Thank you so much, Dr. Zohar. Dr. Toki, I'm going to let you probably take the last question.
Yeah, okay. So it's part of the DKA therapeutic modality for Dr. Noha. You mentioned about the type of fluid. So if there is no cerebral edema, and the patient is improving with the fluid management, is there is a cut point of the level of serum sodium? Can I change IV fluid either from normal saline to half normal saline? This is the question.
Actually, we shift the if we during the management of DKA we have hypernatremia developed with sodium levels more than 155. We change the fluid solution with half normal saline, but after the resuscitation period, after passing the first 2 hours for resuscitation.
Good.
And of course, we have to correct the sodium to the blood glucose level.
Yeah.
Dr. Amir, I'm going to pass it back to you I think we're out of time so that you can conclude.
Thank you so much, Dr. Indira. Thank you much, Dr. Noah and Dr. Khalid and Dr. Turkel Atibi for the greatest moderation and the lectures. And of course, thank for all of our attendees today, more than 360 attendees today we have from 32 countries. Again, everyone should get the attendance certificate by next week. And by tomorrow, you should also receive the YouTube link for our recording webinar. And please stay tuned for our next month webinar. We'll be in touch.
Thank
Have
you.
a good rest of your day, your afternoon, your evening, or your night. Bye.
Thank you very much.
Bye. Bye. Thank you.